Hi, I'm Angela Genge. I am a neurologist. I take care of patients with ALS and people who have the potential to develop ALS. I've been doing this for 30 years. I'm very passionate about finding a treatment and a cure. I started in ALS because I was able to take care of the patients. I was working with a number of people as a young resident who found it very difficult, physicians, world-renowned physicians who had found it very difficult to tell people like ourselves that they had developed ALS. So I was often put in this position of giving the diagnosis, even as a young doctor. I became quite passionate because people with ALS are like you and I. They're people who are healthy, hardworking, physically active, with families and great jobs, and this comes out of the blue. And since the early days of taking care of people with ALS, I've been driven to make sure that people that come to see me get access to the newest, earliest therapeutics in the world for ALS. I really switched from being a regular clinician, neurologist, to someone driven to find treatments because of two or three things that happened almost simultaneously. When I started my career, I volunteered to help my mentor, who was actually an MS doc, in his neuro-AIDS clinic that he'd started. So I was there when the men, mostly men here in Montreal, were dying, and we started getting drugs that helped a little bit, and then suddenly the drugs worked. And I thought, if it can happen for AIDS, it can happen for ALS. Simultaneously, my mentor brought me into the world of clinical trials because he needed what we call a sub-investigator, a doc who does certain tests during the course of the clinical trial that the main doctor is not allowed to do. And because I'd had a background already in internal medicine and physiotherapy, I said yes. And so I got to work on the pivotal clinical trials for multiple sclerosis, which went from 0 treatments when I was in my residency to now like 15 treatments, completely treatable disease now. And concurrently with this, I was starting to see these patients, people who were like me. The first guy I vividly remember was an engineer in his 50s with a leg that didn't work, and they could have been anyone that I knew, and decided that if we can do it for AIDS and we can do it for MS and we can do it for ALS. ALS has taken a little bit longer, but my drive has been related to that. And then there was one final thing that really pushed me to do what I've done locally. The patients I was following were hearing about drugs being developed, but couldn't get in the clinical trials. So I said, well, the solution is for me to bring the clinical trials to Quebec. And I set out on a mission and was unthwarted and was able to really build up what we do here now. So ALS has been described for well over a century, right? It's a very well-known disease in medical history. And there was a family that the major part of the family is in Vermont, that was identified as having a familial form. This is back in the 80s when a lot of this work was done, and several researchers around the world, and it was at the time of the early years of genetics and genetic diseases. It was really early. We knew about genetic diseases, but discovering the genes, we didn't even have the gene from Duchenne muscular dystrophy at the time. And so then there's researchers in a very specific places around the world that started looking for people with family histories. And then by 1992, they had discovered the SOD1 gene, but they realized it was only like 3% of all patients with ALS. And so genetic forms of ALS were just thought to be really rare. These labs looking for these genes kept going, and they're like a hamster on a mill. They kept finding more and more, and they're slowly but surely we were getting more genetic gene mutations found. And then in the mid 2000 teens, like somewhere around 2011-12, I can't remember exactly what year right now, it was discovered that C9orf was there, and it was in a different part of the genes than had previously been looked in. And once C9 was found, we realized two things. One, that some of these big families that we didn't have a handle on were actually C9 families. But we also began to realize that there are people without a family history that actually have a gene mutation causing their ALS. The change in what we do clinically happened around 2012, and for a very specific reason. We knew a certain number of people had gene mutations. We thought it was really small. You had to have a family history to have ALS. And then the first stages of the tofersen trial started. And so we wanted to find everyone that carried the gene mutation. And because C9 had been discovered, we started looking for SOD1 and C9, the two most common. And through that process, we realized that no, it wasn't 2% or 5%, but in fact, there were a significant number of people developing ALS where it was caused by a gene mutation that hadn't been recognized in the family before. And then it was really sealed for me when a woman in her 40s came to see me, no family history. She died in a year and a half. Then, within a year or two, her mother came. So the family history occurred in reverse order. So her mother carried the gene, again died of ALS, and then her sister and her brother both developed ALS. So although it's a 50% chance of the children of somebody carrying ALS, carrying the SOD1 gene, develop ALS, that's in the individual patient. And in a family, you can get more than 50% actually carrying the gene and getting the disease. So that was the final stage for me. So since about 2014, 2015, we've been screening everybody. And we've actually found people who are now on tofersen. We have found a number of families who carry C9 that we're watching, waiting for development of therapeutics, which we're working on. And so it used to be the worst form of ALS. To have a genetic form was the worst because you could pass it on to your kids. Now it's where we're most successful. It's where we have the best treatments, although we have tofersen, we have two others, treatments that are going to be probably even better because either they're easier to give or less side effects. We're changing the game. Access ALS is going to ensure that every Canadian who wants to have access to the newest drug can get it. The point of access is to bring not most, but all of the very early stage clinical trials to Canada and to make sure that it is across, so that we have really that original reason I went after my first trial in 1995, where it's full circle. Now I'm bringing these early trials to every part of this country so that every Canadian has access. We have the perfect storm. We have the talent, we have the kind of medical system that is very supportive of clinical trials. We have a wide geography, so it's very hard for people to get to a central area. You can't have one ALS clinic in this country. And we have people from all backgrounds, which is really important in drug development, that you have people who are white, black, indigenous, any background. We have, and they live across the country. So we have the perfect setup for this, for an early phase network, and we have a very informed regulatory body. Health Canada is extremely informed about ALS. It's going to do 2 or 3 big things and then a lot of little things. It's going to have a navigator, nurse navigator and clinical trial navigator, so that any patient who calls the main number can get to a clinical trial. It's going to support this early drug development at a level that enables these first trials to happen quickly and well, so that the companies can get the molecules or the drugs that are working through the system faster. And it's going to build out these clinical trial setups that are currently early or just doing late stage trials, build out their capacity to run phase 1 trials. So you can go to the clinic in Vancouver or the clinic in Newfoundland and still get into a phase 1 trial.